Welcome to the Orthodontics in Summary podcast, where Farooq brings you the key points and understanding of orthodontic webinars, conferences, and papers in a concise podcast with your host, Farooq Ahmed.
Hello all, and welcome to another episode of Orthodontics in Summary. Today, we're having a look at the lecture entitled Asymmetric Class 2 Malocclusion as part of the Power to Reason series by Cesare, Luzi from Italy. He started off by defining a Class 2 subdivision, or the Class 2 asymmetric case. There is Type 1, where there's a mandibular asymmetry. The mandibular midline is deviated from the facial midline, and the maxillary midline is correct. That makes up the majority at 60%. Type 2 subdivision cases. This is where the maxillary midline is deviated from the facial midline and the mandibular midline is correct. That makes up about 30% of cases. This was Cassidy's paper from 2014. He then went on to speak about the etiology. The Class 2 subdivision case, when investigated using CBCTs, has shown that the etiology is a shorter mandible on the affected side. That was by Sanders in 2010. Interceptive treatment has been proposed. Interestingly, RME has been shown to significantly improve the mandibular asymmetry by allowing a rotational effect to take place. And that was Evangelista in 2020. The second part of the lecture was really focused around treatment mechanics for these cases. Half of it was non-extraction and half was extraction. So, starting off with the non-extraction management for the Type 1 case, where the mandibular midline is deviated. He spoke about using an asymmetric Class 2 corrector, or a monoscope. The advantage of this was that it addressed the etiology of having a shorter mandible on the affected side, as we spoke about in Sanders' paper in 2010. He then went on to speak about asymmetric distalisation for the Type 2 cases, where the maxillary midline is asymmetric. So he spoke about using a modified pendulum appliance with temporary anchorage devices. Now the reason for using both is that conventional intraoral appliances have shown significant anchorage loss of up to 4 millimeters when attempting this, and that's by Grech in 2013. So how does it work? Well, he inserted a modified pendulum appliance. There's a palatal finger spring, which is active on the first molar we wish to distalize, and there's a classic occlusal rest on the premolars. Now, the TAD is inserted between the upper first molar and the upper second premolar. It's indirectly ligated to the premolars on the side we wish to distalize. Therefore, as the pendulum appliance is active and it distalizes the molar, there are no reciprocal anchorage loss forces happening on the premolars. In effect, the overjet can't increase, the premolars can't move anteriorly. He then went on to speak about extraction therapy. The first was 1 unit extraction on the unaffected side. He described how this has been shown to not only allow the centerline to correct, but also the concerns of causing cants has been shown not to occur with unilateral extractions. That was a paper by Jansen in 2004. The final method of extraction therapy was 3 unit extractions. This was the classic paper by Turpin in 2005. It addressed Type 1 subdivision, and 3 units were extracted. 2 units in the upper to manage the Class 2, and 1 unit in the lower to manage the asymmetry in the mandibular centerline. This was considered to be a predictable outcome, allowed the centerlines to become coincident, and the extraction of the lower arch was in the unaffected side. That's it for another episode of Orthodontics in Summary. Hope you've enjoyed the episode. Please do subscribe and look forward to the next episode.